right, welcome everyone, wherever you are, to this HDC webinar. Today we'll hear more about the Harmonization Health Facility Assessment, the HHFA. Our speakers today are Dr. Wendy Venter. She's a technical officer in WHO's Division of Data Analytics and Delivery for Impact. We'll also hear from Dr. Tim Roberton. He's an associate professor of global health at the School of Population and Global Health at the University of Western Australia. We also have Dr. Ashley Sheffo. She's a public health practitioner and researcher at the Johns Hopkins Bloomberg School of Public Health. And last but not least, we have Dr. Heidi Johnstone, who's technical officer in the UNDP, UNFPA, UNICEF, WHO, World Bank, Special Program of Research, Development, and Research Training in Department of Sexual and Reproductive Health and Research at WHO. So we'll have open remarks today from Stephen McFeely. He's director at the Department of Data and Analytics here at WHO. And then closing remarks from Craig Burgess. He's unit head for coordination, governance, and partnerships unit here at WHO as well. So just so everyone knows, these HDC webinar is being recorded, and the recording will be made available via the HDC YouTube channel. And we'll go over the presentations, and at the end of the webinar, there will be a space and a time for questions and answers. So if you do have any questions that you would like to ask our panelists, please add them to the box. There will be a Q&A box showing for you. Now I'll hand over to Steve for his opening remarks. Steve, over to you. Thank you. Thank you, everyone, for attending.
Great. Thanks, Caroline. So good afternoon, everybody. Good morning, good evening, wherever you are, and welcome to our HHFA webinar. So thanks for taking the time to join us. So a well-functioning health facility are required, they're basically essential for achieving universal health coverage and achieving the health-related SDGs. Health facility assessments help us by providing the information that we need on the status of a country's health service delivery system. And unfortunately, that's not usually available from any other data source. So in other words, we have to collect those data. The WHO's HHFA basically provides the evidence for prioritizing systems and strengthening interventions and targeting resource allocation in countries to help them work towards universal health coverage and the SDGs. So a little bit of history. The HHFA builds on and expands the WHO's earlier health facility surveys, the Service Availability and Readiness Assessment, or the SARA. And the HHFA was first piloted in Kenya back in 2018-19 and has to date been implemented in over 14 countries. Most recently, Ghana launched their HHFA results just last week, and Zimbabwe is the latest country to start a HHFA assessment. Over the last 5 years, HHFAs have been tested and refined based on the lessons we've learned through the implementation over those years and across multiple contexts. We've developed a suite of tools to accompany the assessment to help countries not only implement, but to plan, to use the data collection to help them do analysis, interpretation, and most crucially, to help them communicate the findings back to policy and decision makers. WHO's DNA, which is basically the Data and Analytics Unit, we've been leading the development of the HHFA and the suite of products with excellent support from a team of consultants and our colleagues both in HQ and regional colleagues. And I think here we'd like to give special tribute to our colleagues in the Afro region. And again, just on a personal note, I would like to thank Wendy Venter, who's really been leading this work pretty much on her own on behalf of the WHO. But the WHO remains committed to further updating and improving this assessment tool so that we can help countries in implementing high-quality facility surveys that will yield high-quality data to help them with their planning and decision-making. And with that, thanks again for tuning in today. Thank you. So back to you, Caroline, or to Wendy. I'm not sure who's.
I'll hand over to Wendy for.
Thank you. Yes, I'm screen sharing.
Yes.
Thanks.
Perfect.
Can you see my screen?
Yes, perfect.
Okay. Thanks very much for the opportunity. And again, thank you to everybody for joining our webinar today. So in my presentation, I'm going to be giving you a quick introduction to the Harmonized Health Facility Assessment. And Carolina, you're going to have to help me because, okay, sorry, it's sharing now. Okay, so what are we going to talk about in this session? I'm just going to quickly look at what is the HHFA, why conduct an HHFA, how the HHFA is conducted, what is the added value of a health facility survey, and then if you want to do a health facility survey, why specifically choose the HHFA? So what is the HHFA? It's WHO's comprehensive health facility survey. It looks at key facility services and management systems. There's a strong focus on primary healthcare, but we also look at basic hospital services. And specifically, what the HHFA looks at is the availability of services in health facilities and the capacities of those facilities to deliver the services at required standards of quality based on the availability and functionality of resources and systems. And then we also look at whether providers are following the required standards in the care of individual patients. So why conduct an HHFA? We know that all countries are trying to strengthen their health service delivery. Everyone's trying to strengthen primary healthcare and to improve resilience of health systems. And everything is working together to ultimately achieve UHC. We know that to achieve UHC, you need access to high quality health services. So how does the HHFA help in this? We've already said that the HHFA assesses service availability, which is a prerequisite for access, and we also assess the capacities of facilities to deliver quality services. So in this sense, the HHFA can help a country provide information so that they get a good sense of the strengths and the weaknesses and the gaps and also inequities in the health service delivery system. So let's take a look at how the HHFA can provide some of this information. So for example, are some services more available than others? And here we've got an example from the recent Ghana HHFA, where we can see that 85% of facilities offer HIV testing, but only 27% of facilities actually offer ART. Then we can also get information about whether facilities are actually ready to deliver quality services based on whether they have these key resources in place. So again, taking a look at the Ghana HHFA example, here we can see in terms of the percentage of facilities with basic equipment in the main service area, we can see that 96% of facilities have an adult weighing scale, but only 38% have an examination light, and only 13% actually have an ophthalmoscope. Okay, so we can also find out if the sample size is large enough and we can compare different parts of the country, we can see if different parts of the country might be doing better than others. And here we've got an example from the Kenya 2018 HHFA, which compares the percentage of facilities offering diabetes care services among the counties of Kenya. So how is the HHFA conducted? It can be done in two ways. It can be either done on a representative sample of facilities, or in some cases, countries might decide to implement a census of all their health facilities. Data are collected by external teams of trained data collectors who visit facilities. So in other words, this is not a self-assessment by facility staff, and it's not a telephone survey. And the data is collected by the data collectors using a standard questionnaire, which is available in an electronic data collection application, which the data collectors then use on tablets when they visit the facilities. And we should also say that while we have a standard questionnaire, the country has to adapt the questionnaire to their own context and needs. So what kind of data does the HHFA questionnaire collect? Firstly, we look at the services offered, and we call this service availability. Then we look at the key resources such as trained staff, guidelines, equipment, lab tests, medicines, and supplies. and we call this service readiness. We look at whether providers are implementing the correct processes in the way they are caring for individual patients. And we look at this by looking at a sample of patient records, and we call this clinical quality of care. Then we also look at the facility management systems that are in place, for example, human resources, governance, health information systems, quality management systems, and we call this the management and finance component. So what is the added value of health facility surveys? So we know that all countries, when we look at the comprehensive country health information system, they use data from a multiplicity of data sources. For example, population-based surveys, civil registration and vital statistics systems, routine health information systems, etc. So what a health facility survey can do is that it can provide some of the information that is not available from other sources generally. For example, the availability and functionality of the key equipment, lab tests, and medicines for diagnosing and managing a wide range of conditions, for example, TB, malaria, hypertension, etc. This information is not usually available from the other key facility information system, which is the routine health information system. The other important aspect of a facility survey is that it provides an objective assessment by trained external data collectors. And then thirdly, it's a really good opportunity to bring a bunch of stakeholders and different programs together around a set of information. So for example, when the country is adapting the questionnaire to their context, that's an opportunity to bring all the stakeholders together so that they all engage in the survey and they make sure that the questions that are asked are relevant to the context and their needs. And then once all the data is collected, we bring them together again in the country workshop that's going to look at the data analysis, interpretation, and then all come together again to interpret the data within the country context and together decide on how they will be formulating the HHFA report. So I want to just highlight the fact that Ghana launched its 2022-2023 HHFA report this week. Ghana is a really great example of a country where we've had really excellent commitment from very high level in the country and from key multiple stakeholders. This is really one of our showcase surveys. We're extremely proud of them. And if you're interested, you can follow the link and find out a little bit more about the implementation of the survey in Ghana. Okay, so why choose the HHFA over any other facility survey? It's comprehensive. It looks at most of the key health programs. It's based on global service standards. It's standardized. In other words, we've got standardized tools for questions, indicators, and methods. And when we say standardized, it doesn't mean that a country has to implement the survey exactly as the questionnaire appears, because we also have flexibility in that countries can choose the modules and questions they want to implement, and they can further adapt the questionnaire to their needs. HHFA has been tested in multiple contexts, and it builds upon the SARA, which also means that if a country has previously implemented a SARA, they can compare the data from previous SARAs with a more recent HHFA. And then, given that we have a bunch of high quality standardized tools, and we've got good training materials and good technical support, we have the potential really for producing some very high quality data. Another advantage of the HHFA is that this is not only based on reported information from health facilities, but it's actually based on observed conditions in facilities. Perhaps the most compelling reason for choosing to implement the HHFA is this comprehensive set of tools, guidance, and training resources that we have available that can support the country through every step of country implementation. You can find these resources on the WHO HHFA web pages, and we also have a set of e-learning courses that are available through the Open WHO website. One of my colleagues will be telling you a bit more about these resources later in today's session. Thank you very much. And with that, I'll hand over to my colleague, Tim Robertson.
Okay, thanks, Wendy. Let me share my screen now. Okay, I hope you can see that. Hi, everyone. My name's Tim Robertson. I'm going to share some examples now of the type of outputs and analyses that we've done using data from the HHFA. So this year I've been really lucky to work on 3 different projects involving the HHFA. I help support the analysis in Ghana. I'm also currently working with the team in Somalia to produce outputs from their recent HHFA. And I'm also working on a multi-country analysis of health systems bottlenecks that's heavily using the HHFA, which is great for that kind of analysis. So I thought I would talk a little bit about each of these 3 efforts to give you some sense of what you can get from the HHFA. So I'll start with Ghana. Wendy already mentioned how Ghana's been a really great example of the HHFA. And I think the reason why it's been a success is because not only did they do a good job of the survey itself, but then very quickly they were able to analyze the data and produce a set of meaningful outputs or products that were program specific, and the development of which was done in partnership with program teams in the country. So the kind of highlight product from Ghana were these set of 6 snapshot reports, they call them, and they're each about 20 pages on different program specific topics. So there was one on reproductive, maternal, newborn child, adolescent health, one on infectious diseases, one on non-communicable diseases, one on surgery and emergency services, and then one on management and governance, and one on general service readiness. So each of these snapshots had, like I said, about 15, 20 pages of high level or kind of detailed results, but presented in a really approachable way, either just for the country itself or disaggregated by region, facility type, ownership, that kind of thing, and with messages throughout. So it's sort of a report that I'm sure we're all familiar with, but I think that the key aspect of it is that it was tied to the programs in country, and the development of these snapshots was done with the program people. So I'm showing here an example of some of the pages from the RMNCH one, some examples from the HIV one, or the infectious disease one, some examples from management and governance. And like I said, the great thing about what Ghana did was, so they finished the data collection, I think, in February, and immediately, or almost immediately, in March and April, held a series of workshops to analyze the data, and then to have week-long workshops with program teams to interpret those the results and develop key messages and the key results that they wanted to highlight. Part of what enables us to move so quickly with a HHFA analysis is that we have a dedicated analysis platform that allows us to generate tables and figures really quickly once we have the data set. And Ashley will talk about that a little bit later, and I think in our second webinar we're going to show the analysis platform. But that enables us to move really quickly. So in Ghana, in February, finished data collection. Within a month, we'd produced all of the tables, and then the team in Ghana sat with the different program teams from across the ministry and with stakeholders to then develop these findings. So I think it's a really great example of kind of evidence get to policy really quickly and in a meaningful way. And with each of these snapshots, we were able to develop about half a page or a page of key findings that, again, were owned by the program teams. And just recently, when they had the final public dissemination, people talking about how useful these findings are for the country and how they're going to be incorporated into setting the strategic direction for the next, for upcoming national health plans. So I want to talk now about some other types of outputs that I'm helping to produce for the team in Somalia. Now, Somalia have done a fantastic job with the HHFA. It's, I'm sure you're aware, it's not the easiest of settings in which to conduct data collection in very remote rural areas, but the team has done an HHFA in phases, state by state, over, I think, 9 months so far, and I believe they're just now trying to go to the final state. And so it's a really, really incredible job. And what is especially impressive is that they're doing a census of all facilities. And part of the reason for doing a census and part of the value of the HHFA for Somalia is that it serves as a way to validate the ministry's health facility listing. So the ministry has more or less said, this is now going to become the master health facility list for the country, because it was such a detailed and thorough assessment of all facilities, including documenting, the type of facility, the ownership of the facility, the management of the facility. And in my understanding, in Somalia, there can be a difference between management and who's running the facility, who owns the facility. So all of that has been documented, along with lots of other detailed information about the facilities. So this is now serving as a validated health facility listing. And again, we're developing geospatial outputs for this, for different region officers and for district officers. So every region, state, district has a kind of detailed account of the health facilities in their area. So another thing that the HFA is really good for is if you do a census of the health facilities in your country, your area, then it enables you to get indicators around density. So the density of health facilities per population, density of beds, inpatient beds, for example, and density of the health workforce. So, often countries relying on human resources information systems. The HHFA is a good way to, again, get a validated gold standard account of who is working in what facilities. And so in Somalia, they did a census, so we can do this. And again, we're able to get really up-to-date, accurate gold standard estimates of health workforce density. I'm not showing the actual numbers here because we're still finalizing them. So another really nice feature of having health facility data like this is that we can combine the health facility data with population density data to get estimates of the proportion of the population that is within geographical access to health facilities, right? So this is something that the Somalia team has wanted to do, and which we're doing, which is to say, given that there's a certain number of facilities across a country or across a state, and given that only some of the facilities are potentially offering a service or are ready to offer services, then you can calculate the proportion of the population within, say, 20 kilometers or some other distance of the facility. And then say, of those who are within distance to a facility, if someone was to go to their nearest facility or go to, potentially one of 3 nearest facilities, would they be able to receive a service? And you can see here on the right, do some calculations, and we can create estimates of geographical access across the country for different services. So I think what you're seeing here on the left is access to a health facility that providing childbirth or delivery services. And you can see that, by our estimates here, 77% of the population are within 20 kilometers of a facility in this region, but only 33% of the population are within 20 kilometers of a facility who is able to provide effective delivery service. So this is really important. And again, a country like Somalia, good for understanding the placement of health facilities and where there are geographical gaps across the country. Finally, another, I think, really exciting output or product of the HHFA for Somalia is that the WHO team there with the ministry are wanting to create an online platform for all of the Ministry of Health staff to be able to access the HHFA data. So, with the HHFA, we provide an analysis platform which enables country to analyze data and generate tables and figures. But what Somalia are doing is then creating a bespoke custom web platform where we're housing the data along with the analyzed indicators and layering on top of that the geospatial information that you see here. So now every health official in the ministry will be able to do this sort of analysis for their region. And within that platform, we have the actual raw data that health officials can look at and see the kind of binary yes or no, did a facility have this or that, and download that for their own analysis. But then we're also providing a way for health officials to play with, analyze, aggregate, filter HHFA data for their purposes. Because again, as we will talk about, I think in the next seminar, there's thousands of variables that one can get from the HHFA data set, and over 2,000 indicators, default indicators that the analysis platform will create for you. So, and plus on top of that, countries might want custom indicators. So, even if we were to produce a 200-page report with all of this data, there's likely still more to be done, still different ways of slicing the data, putting indicators side by side. So I think Somalia's had a really great idea to create this bespoke portal, enabling all of its different stakeholders to slice the data and present it in the way that they need for their purposes on the ground. Okay, so finally, I've got a few slides here from a multi-country analysis that I'm working on, where we take the data from the HHFA and combine it with both population density data and also combine it with data from household surveys, specifically data on care seeking for services. And I'll explain how we put those two together. But first, this is sort of what we were doing in the previous slide with Somalia. But the idea is that we're using population density data from WellPop, who have publicly accessible and kind of really high quality raster files of where a population lives within a country. And then in our analysis, what we're doing is for every pixel in that image of the country, we're saying what is their nearest hospital, what is their nearest public health center, private clinic, and then we're matching that with data from the HHFA, so we can get estimates of where people are likely to seek care, and if they do seek care from different facility types, are they likely to get care? And all of that enables us to create these coverage cascades, where we can essentially model the coverage of different interventions, or in other words, the proportion of the population that is likely to get effective treatment for different health services. So some of you may have or come across or be familiar with the literature or thinking on effective coverage. And in that kind of field, people present effective coverage as a sort of cascade. So the idea is that on the far left, we have a certain population in need, right? Now, if we're talking about maternal health services, that might be, women of reproductive age or pregnant women. If we're talking about children, it might be all children under 5. In other words, we have a certain population. Then we assume that for all kids who are sick or mothers who potentially need obstetric care, we have a certain proportion of those who seek care for services. And we get that data from the household survey, so from a DHS or from a mix, right? But then we use data from the HHFA for these final 4 parts of the cascade. We can then say, okay, given that a person or a person in need is seeking care from a particular health facility, are they then likely to see a health worker? Is there a trained health worker at that facility of the right CADA with the right skills, we can then estimate the likely competency of that health worker, given what we know about their training and about the competency in general of different CADAs in that country. And then the real kicker is we can say whether or not at that facility, do they have the ophthalmoscope or a delivery bed or the equipment to do a diagnostic test or assessment for a particular condition? And do they have the necessary medicines to then treat for that? Does that facility have magnesium sulfate or uterotonics? Or do they have ORS or ACTs for malaria, right? And then putting all that together, we can estimate coverage for a range of different interventions. And once again, the crucial part is that we need that data from health facilities for these final steps in the cascade to estimate the proportion that are going to get the necessary equipment and supplies for assessment and treatment. This here is just a sort of similar type of analysis, but here we're showing of the population in need, which type of facility are they seeking care from? And this is in dark blue. You see people seeking care from different facility types. Some may then get referred to a public hospital. But once they're at a facility, do they then get care or not get care? And again, the proportion who go green and we think will get care, and the proportion in red who we think will not get care, that's largely determined by the analysis we do using the HHFA data. And as part of this multi-country analysis, we've put this together for about 5 countries for 40 different RMNCH interventions, creating coverage cascades given HHFA data in those countries. And all of that has enabled us to say, what are current coverage levels for a range of different RMNCH interventions. But then, knowing what we know about the coverage cascades, we can then start to model or say what the potential improvements would be if we were to invest in different health system strengthening efforts and increase the availability of supplies and medicines at health facilities, or increase the availability of health workers or the proportion who are trained and those sorts of things. So again, with this data, we can do so many things. And I think this modeling around what we can do to potentially improve service delivery is a really powerful application of that. And I think there's a lot of appetite for that right now. And I think hopefully we'll do more of this in the future. And the very last slide here, we've taken those modeled estimates of potential improvements to intervention coverage. And because it's RMNCH, we use a modeling tool called LIST, or the Live Save tool. And that enables us to turn improvements of coverage into or calculate the potential lives saved from that improvement to health systems functioning to coverage interventions. So this is one slide from one of the countries showing that if we were to improve all the bottlenecks in the country to service delivery and everyone was to get all the necessary interventions, then we would potentially save 39,000 lives per year, child, neonatal, maternal lives. But that's likely to be quite a long way off. In the meantime, if we were to improve care seeking, in other words, get more people to facilities, we might achieve a certain number of lives saved if we were to work around competencies of health workers or the availability of health workers. But then in our analysis, typically, if we can improve the availability of equipment and supplies, we see that we get the biggest gains from any one single health system strengthening initiative. So those are just some examples of the types of outputs that we're producing. In summary, I would say that the HHFA is great because it offers high quality data on over 2,500 health systems indicators at the moment. I've shown you some example outputs, the national reports, policy briefs, those snapshots from Ghana, program-specific reports. In Somalia, we're doing regional profiles, also modeling geographic access, workforce density, and validating the health facility listing in Somalia. And finally, I think, we typically have great population household survey data, And often in countries, this piece around facility readiness is missing. So having high quality health facility data and then combining that with the household population data, I think unlocks many potential analyses that we can do to estimate improvements to health system functioning. So I'm really excited about this, and I hope that was interesting to you. Happy to answer questions at the end of this seminar. For now, I'm going to hand over to Ashley Sheffel, who's going to talk about the HHFA resource package itself. So yeah, there you go, Ashley.
Thanks, Tim. Appreciate it. Let me see if I can get my screen going. Okay, can you guys see that? Yeah. Okay, great. So as Tim mentioned, I'm going to be talking to you guys just for a little bit today to give you an overview of our HHFA resource package. So, really we want to understand how can the resource package support countries? And we know that implementing a large-scale survey can be a really substantial undertaking, and countries need expertise, starting from questionnaire adaptation all the way through to their data analysis and report writing and coming up with their communication products. And so the HHFA resource package really serves to facilitate the survey process and support countries as they implement their HHFA survey. And so we have a number of different components of the resource package. It provides kind of overall guidance, it facilitates capacity building, and then it also provides a set of tools to use throughout the survey process. So I want to provide a little bit of additional information on the components of the resource package. I will first start with information about our guidance resources, which includes the HHFA Comprehensive Guide, the Quick Guide, and the Data Manager Guide. And then I'll talk a little bit about our capacity building resources. And finally, I'll provide a pretty brief introduction to the various HHFA tools, which includes our indicator inventory platform, the standardized questionnaires, an electronic data collection tool using CS Pro, and as Tim mentioned, our data analysis platform, and then finally a global data archive. So we hope to kind of dive into each of these in a little bit more detail, and then certainly open to additional questions. We could talk for a long time. So starting with the guidance documents, we have these kind of three main guidance documents that are aimed to support planning and implementation of the HHFA. The first one we have is the Comprehensive Guide, and this really serves as the main reference document for planning and implementing a country HHFA. So it describes the HHFA background, the rationale, the methods and tools, and it does provide step-by-step guidance for survey planning, implementation, analysis, interpretation, and communication. Next, we have the HHFA Quick Guide, and this is really a summarized version of the Comprehensive Guide, and it provides a more rapid overview of the key technical planning and implementation issues, and really helps readers to understand kind of the main advantages, limitations, and requirements of the HHFA. And then finally, we have the Data Manager Guide, and this really explains how to configure and adapt our electronic data collection tool using CS Pro. Based on changes for the country context, and then it provides substantial guidance for survey data management and the data cleaning processes required for the HHFA survey. So shifting a little bit into our capacity building, in order to build capacity for implementing the HHFA, we've kind of developed a series of online courses that are through the Open WHO platform, as Wendy mentioned earlier. And this includes 5 standalone courses, which covers an introduction to the HHFA. The second one is on questionnaires, indicators, and country adaptation, which will be released by the end of 2023. And then we have a course that's on data collection as a training of trainers course, a class on the data analysis platform, and then finally a course that's on data review, interpretation, and communication. So a little bit more about each of these classes. The introduction course provides kind of that overview of the HHFA, the purpose and methods. It highlights the key steps and the tools involved in planning and implementing the HHFA. And it's really aimed at the country's survey implementation team, as well as other stakeholders who are interested in kind of gaining this general understanding of the HHFA. Then our second course, the questionnaire, indicators, and country adaptation course, really explains in detail the HHFA indicators in the questionnaire and the approach to adapting the questionnaire to the country context. And so this is really targeted towards the participants of a country questionnaire adaptation workshop. And then we have our data collection training of trainers course, which is really aimed at the facilitators of the in-person data collection training workshop and provides them with the core knowledge they need to really facilitate the training sessions for collecting HHFA data from health facilities. Next, we have the data analysis platform course, which is really targeted towards data managers and data analysts, and it provides the core information needed for using this HHFA data analysis platform in order to analyze the data set and produce the core indicators, tables, and graphs. And then finally, we have our data review, interpretation, and communication course, which has really been designed to help describe, understand, and extract meaning from the information produced by the HHFA, and then to communicate all of our key messages in effective ways. So this one is also aimed at the core survey team and other stakeholders that are involved in producing the HHFA reports. So in addition to our open WHO e-learning courses, we have an HHFA data collection training package, which is intended for use in the context of an in-person country HHFA data collection training workshop. And this package includes a facilitator's guide, PowerPoint presentation, exercises, and other tools for facilitating that type of workshop. And then finally, all the packages that are used from the e-learning courses can also be made available as PowerPoint presentations if you'd like to use these as more of an in-person training setting. Okay, so now to talk a little bit about the HHFA tools and how they're related. So we'll start with the indicator inventory, which is a repository of all of the indicators that can be collected with the HHFA questionnaires. Then we have the standard HHFA paper questionnaires, which have also been programmed in CS Pro, which is an electronic data collection platform, so that we can do data collection on tablets in the field. After we collect the data, it's exported from CS Pro and uploaded into the HHFA analysis platform, which calculates the standard HHFA indicators and displays them in tables, graphs, maps, etc. And this generally forms the basis of our country report. And then finally, we have our data archive, which is available for countries to make their final reports and/or data sets available if they would like to. So I'm going to provide a little bit more detail on each of the tools, starting with the indicator inventory platform. So as I mentioned, this indicator inventory platform is available online. The link is shown here, and it displays all of the indicators that can be calculated from the HHFA. So it includes information on how the indicators are expected to be tabulated and organized in the HFA reports, as well as the survey questions and code that are needed for calculating each and every indicator. So this platform provides kind of a quick way to understand the content, but also allows you to take a deep dive into very specific indicators and their calculation. There's also the ability to download the indicator inventory as an Excel document from the inventory platform. So next, just a little bit about the questionnaires. The HHFA questionnaires are provided kind of in a standalone format and then also in combined formats. So the standalone questionnaires are available for each module, meaning readiness, availability, quality of care, and management and finance. And then the combined questionnaire integrates the questions from availability, readiness, and management and finance modules into a single questionnaire to streamline data collection in the facility. And all of the questionnaires can be and should be adapted to the country context. So next, just a little bit about our CS Pro electronic data capture program. Our questionnaires have already been programmed into CS Pro, which is an electronic data collection tool that can be used on tablets or mobile phones to collect data in facilities. And the tool enables countries to select the questionnaires and the questions they want to implement, and then to adapt the tool to the country context. Our current tool also allows for assignment of questionnaire sections to data collectors, which allows for multiple data collectors to collect data for the same facility at the same time, and provides data collectors with additional flexibility in how they complete the questionnaire. And our core standard CS Pro application can be downloaded from our GitHub site, which is also linked to the WHO HHFA website. Okay, so now to talk just a little bit about the analysis platform. So our HHFA analysis platform is an online web application that can be used to conduct all of the analyses required to produce a standard HHFA report. So the platform kind of automatically calculates the standard HHFA indicators and produces a set of analysis outputs in the forms of tables, charts, and maps. And the structure of this analysis is consistent with the organization of the indicators and tables in the HHFA indicator inventory platform. And this data analysis can also be configured to country needs, to add additional indicators, to make customizations, etc. And the idea with the data analysis platform is that it's really designed to enable quick and easy analysis of an HHFA data set and really reduce that time that we spend waiting between data collection and having results to take a look at from our survey. So how does it work? Well, a country kind of uploads their clean data set after they do their data cleaning in CS Pro. And that's what you kind of see here is our data set has been uploaded. Then there's a minimal number of configurations that need to be set, including kind of setting your stratifier, specifying if you're using weights, etc. And then we're able to take a look at our tabulation. And the default tabulation is provided. We can customize this as needed. And then we're able to run the results, and we get a set of tables and graphs that we can then further customize for the country context. All of the tables and figures that are created can also be output into a Word report and a PDF, ideally within a few hours of uploading your data set to have preliminary results available. The platform does run fully online. It does not require any software to be downloaded or installed. The user can simply kind of navigate to the website and start using the tool. And the other kind of advantage here is the platform does not require users to be super familiar with any advanced statistical software, but they will need kind of a foundational understanding of descriptive statistics to be able to, interrogate the results from the analytical outputs and then to kind of configure any required custom indicators. And again, here's the link to the analysis platform for those who are interested in taking a deeper dive and having a look around. Okay, and then I wanted to just mention briefly our kind of global data archive. We have the HHFA and the SARA survey reports are available for download in the data archive, and the link is provided here. We're hoping that at someday in the future, survey metadata and microdata will be accessible where authorized by the country. And so the way this data archive works is that when countries have completed their survey and finalized their report, they have an option to contribute to the archive, and then they'll be posted here for the general public to have access to. So I know that was a very quick rundown of our resource toolkit, but please feel free to take a look at the links provided to get more familiar with the various tools, and reach out to us if you have questions, and we're happy to answer them. So thanks very much. I'm going to pass things over to, I believe, Heidi to continue on.
Wonderful. Thanks so much, Ashley. Let me share my screen. And you can see that. Great. Okay, so thanks very much for inviting me as a speaker for this webinar. I'm very happy to speak about the process. So it's sort of more in depth or application of what Wendy and of what Ashley and Tim have been speaking about. So it's the process of incorporating abortion indicators into the HHFA. We know, or we have a background at WHO where our guidelines supports comprehensive abortion care to be effective, efficient, and accessible. However, we want to measure the operationalization of our guideline recommendations, and data on abortion services are fragmented and scarce. So when we learned about the opportunity to include abortion indicators in the HHFA, we knew this was something we should take advantage of. The process that I'll be presenting is very much a WHO 3-level cross-divisional, multi-region, and multi-year effort with leadership from multiple countries, including Pakistan, Burkina Faso, Zambia, Uganda, Ghana, and more. I'll go through the steps of this process from question set design to dissemination and impact as a way of sharing the experience. Our initial assessment was 12 district SARA, the Service Availability and Readiness Assessment in Pakistan. And our abortion question set was based on examples from other SARA service-specific modules, WHO abortion care guidelines, a review of abortion and post-abortion care assessment tools, expert review, and importantly, a stakeholder review of final questions during a 2-day meeting for the entire tool that was held in Pakistan. And the stakeholders were the Ministry of Health, provincial health departments, and implementing partners. And for the Harmonized Health Facility Assessment, we basically used the same question set, but always learning and adapting slightly based on our learnings, and a similar process of stakeholder consultation in each country. With a sensitive topic like abortion, we knew there would be benefits to being engaged beyond the development of the question sets, at least in the very early implementations. And so in Pakistan, the country office reproductive health focal points were very much engaged with the SARA steering group, emphasizing the importance of including the abortion indicators and what we would learn from that. In Uganda, we had the Health Information Systems Technical Officer, Nasa Natsiri, coordinating regular virtual meetings, keeping stakeholders informed and engaged. And so we had stakeholders from the Ministry of Health, the implementing institution, Makerere University, the WHO regional office, and WHO headquarters, all engaged on a regular basis. And these meetings really facilitated transparent, respectful communication, and there were disagreements and dialogue. And I think we all were able to discuss, and I think the survey really benefited from these regular open meetings. From pre-testing and prior implementation, we learned from Pakistan that the sensitivities around abortion needed to be addressed. From Burkina Faso, and I think from Zambia as well, we learned that the HHFA tool, including the abortion set of questions, needed to be shortened. And from the Zambia experience, we learned to make sure that unnecessary skip patterns are not applied, for example. Also, we had the opportunity to have different countries learn from each other's experience. So in Pakistan, we had an in-depth pre-test of capital territories and lessons learned from this experience. Right when Burkina Faso was developing their tool and their abortion question set. So they were able to have dialogue and really learn from each other. And that was a great experience. I want to talk briefly about the picture here. It's one of my favorites. We have the 3 levels of the organization all focused on one output, one aim. So this is Olive Sintumbwe from WHO Uganda, and in the middle, Amaka Onia from the regional office, Africa, and then I'm in the corner, and we're all filling out the abortion quality of care record review tool in Uganda as a pre-test. We addressed potential sensitivities around abortion in the HHFA training modules. So as a group, we had decided that it was important to include abortion care with other areas of care to normalize rather than silo abortion care. And we included in the interview training a brief values clarification exercise covering a range of topics. For example, abortion, HIV, contraception, violence against women. And the purpose of these was to promote dialogue and not exclude from dialogue these stigmatized topics, and to recognize the diversity of opinions in the room about different stigmatized topics, and to recognize that no matter what diversity or where one falls on that spectrum, we all believe that no life should be lost from complications of unsafe abortion, and that's what we're working towards. We also included role playing in the training and discussed actions to take if a respondent is reluctant to talk about abortion or another stigmatized health topic. Huge teams collect data as part of the pretest and the actual assessment. This is Team North Central from Uganda. And we had a WhatsApp app chat for the Uganda implementation where everyone was kept informed of, for example, the flat tires that were had, the boat rides to get to different service points, the unidentifiable foods that were eaten while on the road, and of course, technical questions as well. Skipping right over the important steps of analysis and report writing to get to the report and recommendations, the Burkina Faso report contains evidence-based recommendations for strengthening availability of safe abortion care. So these include improving drug availability at the PHC level, transitioning away from dilation and curettage to safer technology, improving accessibility of care. And I just want to emphasize that it's really exciting to have recommendations based on nationally representative evidence. In Pakistan, we have the Ministry of Health using health facility assessment data for evidence-based planning. So again, it's very exciting to see that the abortion data are being used to improve service delivery. And in this case, the health facility assessments informed district planning on expansion of facility readiness for therapeutic abortion, inclusion of misoprostol in the routine DHIS2 logistics monitoring, and the need to increase the focus on health worker training in rural areas and urban informal settlements. Findings from Pakistan were published in a peer-reviewed journal in Sexual and Reproductive Health Matters. And Dr. Mahapala, the representative from Pakistan, is here on YouTube summarizing findings from joint peer-reviewed publication by the WHO and the Ministry of Health and the implementing partner, which in this case was University of Manitoba, based in Islamabad. And so we're really excited about next steps. The Africa Regional Office has secured funds to support a multi-country workshop and is supporting analyses leading up to the workshop. And the workshop is to review and disseminate evidence from health facility assessments, including the new abortion module, and it will include participants from the different countries, the WHO country offices, the Ministry of Health, and the implementing organizations, the regional office and HQ. And will include discussion of lessons learned, challenges, processes, evidence, and the implications of the data. Of course, next steps will also include continued learning and continued data collection. And so thank you for this opportunity to present some of our process. And I hope I was able to get across the extent to which this has really been a collaborative effort with the country offices, the regional offices and headquarters engaged, multiple divisions working together with multiple regions and multiple countries. And Finally, as a result of including abortion indicators in the HHFA, we're beginning to have nationally representative data to identify gaps and prioritize areas for program improvement for safe abortion care. And as someone who's been working in this field for decades, I can say that this is a significant step forward for efforts to reduce unsafe abortion and reduce related maternal morbidity and mortality. So, thank you.
Thank you very much, Heidi, Ashley, Tim, and Wendy. So we have quite a few questions on our Q&A box. Wendy, how would you like to take those? I see you've tagged some that the team would like to enter online. So should I go one by one and read those over?
Yes, thank you. That would be helpful. So I think they just start from the top. I'll be answering some of them and I'll be referring some of them to some of my colleagues. Thanks.
Right. Thank you. Thank you for all participants who post questions on the Q&A box. Please do note that some of them have been directly responded in the Q&A box, so either by Wendy or Tim or others in the team. So if your question hasn't been read out loud, it has probably been answered directly on the chat box, right? So first question from Michael Washington from CDC South Africa. Thank you, Michael, for your question. I like the outcome you had about the impact of improving system, your second to the last slide, but you do not indicate the cost to implement those interventions. So of course you would save lives and eliminate bottlenecks, but how much will it cost to eliminate them? So some interventions require almost no cost, but there are costs with other interventions like additional staff, space, supplies, and other resources. So to the team of panelists, could you please address and expand a bit more on the costs to implement the interventions proposed by the HHFA? Thank you. Over.
Yeah, thanks, Michael. That's a good question. And obviously you're right. Yeah, no, we're in the modeling we're doing, we're only doing the benefits side of what would be a cost benefit analysis. I mean, I suppose just argue that actually getting, good estimates of the potential benefits from different policy options is really valuable because, you do need them. And I think, the costing is perhaps a little more country specific. And I think to do it meaningfully, you would want to sit with the country and, have conversations around the feasibility of different potential policy options and then cost them with their country data. Although I know that there are global, efforts to develop generic costing tools. But yeah, I guess the short answer is that, we're really focused on the benefit side, but that's a necessary, if not sufficient, part of a modeling exercise.
Right. Would anyone else would like to intervene, or should I go to the next one? Right. Next question then from Raza Zaidi. Can we have a rough estimate of UHC service coverage index in the catchment area of a PHC health facility?
I believe so. Yeah, I don't. I actually have not yet personally calculated that, but if it's simply a matter of estimating coverage for the tracer indicators, and then making a composite indicator, and then doing either geospatial stuff for that, or aggregating it for a country at region, district, whatever. Yeah, I don't see unless one of my colleagues can see an issue with that. I imagine that's would be a good thing to do, and I might take that back to the teams I'm working with to suggest that we do it.
Yeah, I agree with Tim's response. I think the one challenge is kind of defining catchment areas. And if you take a kind of geospatial approach and we're making some rough estimates, it seems very feasible. If you want really specific catchment area population, that can be really difficult in some countries.
Thank you very much, Tim and Ashley. Now on to the third question from Remy Mwamba, UNICEF. You answered my question about how the HHFA can support and strengthen the process and accuracy of the master registry system. However, not all countries will engage in a census-based HHFA. What is your perspective on strengthening HHFAs in countries that intend to conduct survey-based HHFAs? Thank you, Remy, for your question. Over to our panel.
Thanks, Remy. So that's a good question, because in fact, most countries don't do a census because it's simply very expensive. But you can still use the HHFA data, and what you can do with it is going to depend to some extent on the sample size. So if the sample is calculated in such a way to give you national level estimates, you can still look at the overall performance of the system, and you can make comparisons between different programs in terms of availability and readiness, etc. Then if the sample size is big enough and conducted in such a way that it allows sub-regional or sub-national comparisons, then obviously you can take your comparisons a level further. What we can also do, even at a national level estimate, is we can compare different facilities, we can compare different facility ownership or facility management authorities. So there's still a lot that you can do. In fact, a great deal that you can do with this data, even if you aren't actually implementing the survey as a census. Tim or Ashley, would you maybe like to come in with something further?
Yeah, maybe just kind of back to this kind of master facility point. I think it's important to note that if a country is planning to implement the HHFA as a sample survey, they do need to have a master facility list that is quite up to date to serve as the sampling frame for that survey. So that is kind of a prerequisite. If you don't have that, then we do recommend, like in the case of potentially Somalia, doing a census in order to create that frame as well. And then always the data can be helpful for updating that master facility list that you have. We find facilities have been upgrading and the managing authorities have changed, and so all that information can be fed back into your existing master facility list.
Thank you, Wendy and Ashley. Now on to the fourth question from Jigyasa Sharma from the World Bank, I believe. Could you kindly provide insights into the strategies employed to ensure quality assurance and standardization in survey implementation across various countries? I'm curious to understand whether these processes are centrally coordinated and supervised by WHOHQ, or if regional teams are involved in overseeing these efforts.
Yeah, sure, I can try to answer that a little bit. I think the HHFA is a bit unique in that it's really a country-led process. And so, ministries of health decide that they're interested in having the data that's available in an HHFA, and they start the process for, kind of undertaking the survey. And that usually involves coordination with the WHO office at the country level, at the regional level, and at headquarters. And there's various supports for request. So in many of these early HHFA implementations, the kind of WHO HQ team and the regional team has provided, substantial support for country implementation. But we've also prepared this resource toolkit so that, countries can implement without, Tim or Wendy or I being present for the implementation. And so countries have taken various approaches. Some have had, consultants come to help with their training of data collectors. Some have had people come to help with the analysis platform. Some have had, a lot of strengths in one of those areas and been able to take on that work themselves. So it's a bit of the way the implementation happens in the country is different, but we try to ensure standardization by providing a substantial resource toolkit that is quite detailed and provides the training that people need, and then being available as support resources as needed and as requested.
Thank you, Ashley, for the answer. And thank you, Sharma, for your question. From Catherine Andrews, can you clarify what the harmonization process was, and with what surveys the HHFA is harmonized? Both USAID Service Provision Assessment, the SPA survey, and the World Bank Service Delivery Indicators, SDI, health survey. So both these health surveys have been fully revamped in the last couple of years. Does the HHFA draw on those innovations?
I can try to answer this, and I might combine it with the question from Sarah Reese about the similarities and differences between, the SPA, the SARA, the HHFA in terms of kind of content, methodology, resources. So there are a lot of similarities between these different health facility surveys, and there's some key differences. I think between the SPA, the SARA, and the HHFA, they all include a facility inventory component that collects information on kind of, basic inputs to the health system. In the past, the SPA and the SARA, which is now the HHFA, had done a harmonization process on a set of core indicators. And for the HHFA, those core indicators are still included in the HHFA. I know that SPA has kind of undergone a pretty recent revamp, and so I think there's need to kind of revisit and see if there's still harmonization in those kind of core set of indicators. In terms of some key differences, I think when we look at kind of clinical quality of care and experience of care is where we start to see some differences between the tools. The SPA does a direct observation of care for a number of services, whereas the HHFA does a record review for a number of services to look at clinical quality of care. And then I think the SDI, and please correct me if I'm wrong, I know there's experts here from the World Bank and DHS and others, but has their, instead of doing kind of direct observation or record review, they do a provider vignette that looks at kind of health worker knowledge. And so kind of a different aspect or different approach for measuring that aspect of quality of care. And then I believe both the SDI and the SARA have kind of a client experience, patient satisfaction approach to collecting data, which is still a TBD component of the HHFA. So certainly some differences. I think countries should choose the tool that best fits their needs. I don't think there's necessarily one right tool. And then hopefully the harmonization process will continue moving forward. I think there were some efforts to harmonize a number of years ago, and then it takes a long time to get this stuff done. And in that time, both the SPA and the SDI had a major revamp. And so I think we welcome the opportunity to continue the conversation about harmonization. And definitely please reach out to the team, reach out to Wendy, so we can continue those conversations and improve harmonization going forward.
Thank you, Ashley. Anyone else would like to tackle, and now that Ashley collapsed those two questions into one? Anything to add? Okay. From Dave Boone, any reluctance on the part of countries to put their raw data from HHFA on a global repository? Thank you, Dave, for your question.
Thanks, Dave. Yeah, I can take this one. And that is a tricky one. And I think the short answer is it depends on the country. For us, we don't even publish country reports in our global archive unless they are already published or unless we get explicit written permission from the countries to do this. So that's just reports. We haven't even got to the raw data yet. What I think probably happens is that, okay, there's a mix. Some countries are never going to let you publish their data or even their reports. Some countries probably have no problem with it at all. But I think things sometimes break down simply in the process of getting the right permissions. And it's simply something that takes a lot of follow-up. And I think it's something that we'll try our best to pursue a little more intensively as we go forward, because definitely we would like countries to be able to at least publish their reports as much as possible. And then hopefully the next step will be to be able to make some of the raw data available as well. Thanks.
Thank you, Wendy. And just a comment from Sarah in response to how the panelists answer her. She says, thank you, I agree, would welcome opportunities to continue conversations about harmonization of tools. Thank you, Sarah, for participating. Right now from Teddy, thanks for joining, Teddy, and thank you for your question. Do you provide additional resources for completing the MFR? Ethiopia, as an example, has yearly data verification. They haven't done the complete data collection and verification. Are there any resources available for this activity?
Let me try to answer that one. I'm not sure I understand your question very well, Teddy. So the HHFA isn't specifically an exercise to update the master facility list, but it happens in any case if you implement the HHFA as a census, and then also, as Ashley has mentioned, even if a country wants to implement the HHFA as a sample survey, the master facility list has got to be updated to use as a sampling frame. But there are other resources definitely within WHO that can support countries in terms of updating their master facility lists. And I can put you in touch with the relevant colleagues who are managing those resources if you'd like to contact me separately after the webinar. Thanks.
Thank you very much, Wendy. Just a reminder to everyone that a few of the questions have been responded directly in the chat box. So if your question wasn't read out loud, it probably has been addressed. It certainly has been addressed directly in the chat box. We're 10 minutes away to the end of our webinar. Right. Thank you for the comment, Adinka. So we're 10 minutes away to Wendy, would you like to comment on the last comment? Before I call to any other, if you have any other questions, participants, please feel free to type them directly in the chat box. We can still take questions for another 5 minutes. Wendy, over to you.
Okay, this is just the comment about Nigeria conducting a SARA and an SDI. That's great, and we look forward to seeing your results. And next time, if you would like to conduct an HHFA, we would be happy to support you.
Thank you, Wendy. Thanks, Latinka. So anyone else? Last chance. Right. Would the panelists like to make any, final wrap up, any other comments to what has been asked so far? While some people are just shy and just need to take 2 minutes to type a question. We still have a few minutes for Q&A if you'd like. All right. So Wendy, should I hand over to you for any final remarks before the closing remarks from Craig?
Okay, thanks, Carolina. Well, thank you very much to everybody for joining us for this webinar, and thank you very much for some really interesting questions. One thing that I would like to mention is this is the first of 2 webinars. So today we kind of gave you the perspective of the tools. But in our next webinar on the 14th of November, we're going to be hearing from 3 countries, Somalia, Ghana, and Maldives, who all implemented an HHFA. So we'll be getting their experiences in what went well, what didn't go so well in implementing the HHFA, and most importantly, how the country has been able to use this data going forward. So we'll really invite you all to join us for that. Thank you very much.
Thank you, Wendy. Craig, I believe now we're to hear you for closing remarks. Thanks.
Thanks, Carolina, and thanks everyone for joining today. My name's Craig Burgess, the Unit Head of Data Coordination, Governance and Partnerships in WHO. You heard from our Director, Steve. We've heard today the how, the what, the why, the where, a lot of the HHFA, and the huge amount of work that has largely been led by my colleague Wendy Venter, together with her team. A huge thanks to Heidi, Ashley, Tim, and also many of the country colleagues and regional colleagues who've not only given inputs into the process and sound technical reality check, which we always appreciate, making sure that everything really is real to this process. You've also heard how the HHFA, most importantly, can fill data gaps in knowledge that can be translated to policy, programs, budgets, and we even heard modeling and estimates as well. So as we look at SDG, UHC, or PHC goals, I think we're all aware of the huge numbers of data gaps that we have, and this is one tool which is emerging as an important tool within a context of SCORE. And I mentioned SCORE, and I think a couple of participants mentioned it as well, as potentially one of a suite of tools that can help support many contexts in a country-specific way to address some of those gaps and look at ways of gathering more data in a much more harmonized way, decreasing reporting burdens for information that's needed by countries, as Wendy and colleagues mentioned. So on that, I want to thank everyone for joining, and especially to the donors who've helped contribute financially to this process. As Wendy is saying, there'll be a second webinar that's happening in November next month. But we look towards other partners, not only for financial needs, but technical support to continue the momentum that the HHFA process has generated. And you've heard a lot today. You'll hear more in November. And then lastly, I'd like to thank everyone for joining in terms of the HDC partnership. This is a collaborative platform. It's informal. There is an email address, there's a YouTube channel, and we welcome any contributions for any webinars that people want to host. That includes not only showcasing work that you've all been doing and sharing that knowledge as part of our knowledge brokering function, but also any country-specific case studies you wish to share or region-specific issues you want to raise as well. We were thinking also in the HDC that these webinars could be used as a challenge and solution type of arrangement as well. So we're very flexible in what you might want to use the HDC as a platform to share with other colleagues across the globe from multiple levels and from multiple entities as well. So with that, thanks Carolina for helping to host us. Thanks again, Wendy, for leading. As Steve said at the beginning, you've been, you've really been alone in this work in many ways. It's been led by you, but want to thank everyone who's joined Wendy's leadership for this, the colleagues who presented today, and most importantly, our colleagues in countries and regions who've helped keep us real. Thanks everybody for joining, and hope you can tune into the next HGC webinar. Thank you.